Okay, we are now being recorded. This is official. And I am officially still Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium. And we are very excited. We have one more person joining. We're very excited to be partnering with the Samueli Foundation on launching this integrative health learning community. Wayne and I and his team have been talking for quite some time about this. And the larger goal from the point of view of the Family Medicine Education Consortium is to help transform primary care practice in residency programs, federally qualified healthcare facilities, independent and hospital-owned practices. And this learning community, I think, has the potential to transform healthcare in America, particularly at the primary care level. So we may be small to begin with, but that's how most beginnings happen. They're small, they're humble, and quite often there's a fair amount of stumbling as we get our sea legs and figure out how best to do this. So I'm very excited that all of you have joined with our call today. Our goal over the next month is to find 10 to 12 organizations that are interested in being a part of this learning community. The FMEC has a fair amount of experience organizing learning communities. Our largest project is called the Implicit Project, that now has 30 residency programs across the United States working on reducing the rates of low birth weight and premature birth. And it's been a very successful collaborative, and we are hopeful in the long run that this collaborative will develop and, as I say, begin to transform residency programs as well as the practice, particularly in family medicine. So with that, I think it's probably best to go around, and I'll end up with you, Wayne, but I'm going to start. I'm just following the images on my screen. Aman, would you like to introduce yourself?
Sure. I'm Dhaliwal, Program Director, Central Michigan University Department of Family Medicine in Saginaw, Michigan.
Great. Elena?
Get myself off mute. So Elena Rosenbaum, I'm a faculty member at Albany Medical College Family Medicine Department, and I've also been working with Wayne and his team on teaching, the integrative health around several conferences and in my own practice, residency practice, to residents and faculty. So I'd be part of the faculty in this learning collaborative.
Great. Doug? Doug, you're on mute right now.
Sorry about that. Hi, everybody. I'm Doug Caparocchi. I'm the Deputy Director of Samueli Integrative Health Programs.
Great, thank you. Denise?
Yes.
You want to introduce yourself?
Sorry, I had to go away. Yes, I'm Denise Steele, and I've been, can you hear me?
Yep.
Okay, something just weird happened with my computer. Everyone looks frozen there, but you can hear me?
I can hear you, Denise.
Okay. I've been with the FMEC for 7 years, and I'm happy to be a part of this project, and help in any way that I can. So I typically manage the online registration and membership for the FMEC, so let me know how I can help help it grow.
So the folks at Jamaica Hospital?
Hi, I'm Mika, and I'm one of the faculty attending for the family medicine residency here. We've been working with Dr. Jonas for a year or 2 years now on implementing integrative medicine into our hospital, our network, and it's been really great. I'm also doing a Integrative Medicine Fellowship through the Andrew Weil, the Arizona Institute of Integrative Medicine. So in my second year of that. And we also have 3 residents doing the integrative medicine and residency program. So really enthusiastic about it. And Kristen, if you just want to say hi.
Hi everyone, I'm Kristen Lacey. I'm the coordinator for Integrative Health here at Eureka Hospital. I actually started in May, so I'm still learning a lot, but we have been working a lot with Dr. Jonas at that time. It's very exciting. It's nice to meet everyone.
Yeah. And Dr. Rob and Dr. Costello are also doing some IMR faculty training and working with Dr. Jonas as well.
Great. I'm going to go down to Mary Jo Wagner.
Hi, I'm here with Bethany Bigford, the GME office, supporting Dr. Dhaliwal.
Great, welcome. And Heather?
Hi, I'm from the University of Washington, Family Medicine Department, and the Chronic Pain Division as well. And I've been an integrative physician for more years than I care to say, since the beginning of my practice. And I'm going to hope to play the role of facilitating the introduction of more integrative medicine within the family medicine department, where I don't work clinically, but I do have a role to play. And my colleagues couldn't be here today.
Great, thank you. And I think I've gotten everybody. So Wayne, the ball's in your court.
Okay, thank you, Larry. Appreciate it. So I'm Wayne Jonas. I oversee something called the Samueli Integrative Health Programs. It's an initiative by the Samueli Foundation, which is a philanthropy out in California that's interested in making integrative health, as we'll describe it, sort of more routine and regular. So we'll talk a little bit about what it is that we're doing. We've been working with a number of systems, organizations, hospitals, networks of providers over the last couple of years to try to facilitate and help them implement tools to make integrative health easier to do, something that can be done in routine practice, and begin to get at and address sort of underlying root cause and determinants of health. And I'll show you some of those tools in just a minute to illustrate that. I noticed we had somebody else join. Larry, you want to
Yes, so
ask
Lori
them to go ahead
Medina.
and introduce themselves?
Lori Medina, would you like to introduce yourself?
Yes, sir. Sorry for the late addition. My name is Laurie Medina, and I have been offered the position for director of the Centers for Life at UNM. And Dr. Ivers invited me to the meeting.
Mm-hmm.
Awesome,
Okay.
welcome.
Great. Wonderful.
Thank you.
And so what I'd like to do is just spend a few minutes, maybe about 10 to 15 minutes at the most, just giving you an overview of what this Learning Collaborative is about who's involved, some of the resources that we're making available and FMEC is making available to help practices begin to implement this in a more routine basis. And some of the requirements that we'll be asking from those who join, and then talk about sort of the process of joining and that type of thing. This is one of 2 Q&A sessions that we're having over the next month, with the idea that then we would have sufficient numbers of practices to begin to learn from each other, which is a key part of Learning Collaborative, as various practices begin to implement these things over a period of 9 months after it gets launched in the fall. Then they begin to learn from each other, troubleshoot, problem solve, and more readily implement within these practices. So I'm going to share my screen brief and just begin and just give you a brief overview of what it is that we're about and this project is about. So let me just see if that works. Are people able to see that? Thumbs up,
Yes.
thumbs down? Okay, great. And so this collaborative is between Family Medicine Education Collaborative and the Samueli Foundation. I've used the title Integrative Health, but as you'll see, it is also using person-centered care as sort of a point approach to actually providing this. And I use the term person-centered rather than patient-centered very deliberately here, as you'll see. The tools we're looking at are designed to incorporate the patient into the process on an ongoing and initial basis. First, let me describe what it is that we're talking about trying to see happen within practices more routinely. Let me define what we mean by integrative health. So our definition of integrative health involves the seamless merger of three different areas. One, the conventional type of care that we normally deliver within mainstream primary care, the pills and the procedures and things like that, the stuff you learn in medical school, the stuff you put in a SOAP note, the stuff you put into a CPT code that you get billed and paid for. Merging that with what's sometimes called complementary and alternative medicine that's evidence-based, that has evidence, not all types, and we'll show you the ones that we believe, at least based on current guidelines and recommendations around the country and large programs, are the ones to consider. Many of you may already be doing many of these. I hope you're doing many of these. These are often non-pharmacological approaches. And then crucially, the third part of this merger is self-care or behavior and lifestyle. We know that, things like nutrition, stress management, exercise, those kinds of self-care practices are actually crucial to the prevention, mitigation, management, and even reversal of chronic illnesses. And so that is an essential component of what we define as integrative health. Now notice all of that has to be done within the context of the person's personal and environment. And as unfortunately COVID has shown, we've known it for those of us in primary care for a long time, but COVID has shown a spotlight on that. The social determinants of health, the economic and social aspects of it are increasingly an important thing that need to be addressed within this. And so we have tools to begin to do that, and many of you have those things ongoing in your practice also. So this is the definition that we have of integrated health. We intentionally use the term health rather than medicine. This is not simply putting in acupuncture, putting in a new medical treatment that a professional needs to deliver, although some of those are important and they're part of the complementary and alternative medicine aspects. But it is really about self-care. So that means bringing the patient into the component, which is why we call it health. Now, I'm going to pause there briefly and just ask if there's any questions about that, because I want to be very clear to everybody what it is that we're looking at the Learning Collaborative is focused on. I know there's a lot of terminology that flows around in this area and differences, and you all have many of these things already in your practices. And our goal here is to make it easier to deliver that in routine care. So any questions around that before we sort of go on to the other aspects? Okay, hearing none with sufficient pauses for unmuting, I hope. Let me go on to what the Learning Collaborative's goals and objectives are. They're actually pretty simple. They have it listed out here in 5 areas. But the primary thing is understanding the role of non-pharmacological and self-care approaches in primary care for reducing risk factors of chronic disease. And I dare say reducing risk for COVID, because as it turns out, the risks for serious illness in COVID all parallel the things that kill people with chronic disease, standard types of conditions like heart disease, diabetes, obesity, as well as, apparently racial and ethnic issues. Those who are poor, et cetera, are at higher risk. Now, most of you all will understand all of that, but we're going to just make sure that that gets reinforced at the beginning. Then we'll introduce a set of tools, and these tools are not exclusive to anything else. They're really process tools, the goal of which is to facilitate the easier insertion of integrative health into routine care. We call them the Hope Note tools. They've been developed by our organization, and they are now out being implemented and tested in a number of clinical networks, around the country. In fact, we have the Jamaica Hospital System, which we've been working with a couple of years, and they've been implementing them there. So this learning collaborative will help accelerate those who are already doing this, as well as we'll have the ability to learn from you all in those areas. We also then are looking to implement these kinds of visits in a subgroup of patients within your clinic. So what we're hoping is that there will be a cohort of patients during the 9 months that you can select, and that's up to you as to what that cohort looks like. It can be chronic pain patients, it can be advanced illness patients, it can be a general mix of chronic disease patients. That's really up to each clinic as to how they want to implement it, but we would be looking for implementation of sort of a minimum number, reasonable number that can be done over the 9 months in those areas, depending upon the number of providers that are involved. We then are looking to collect both process and outcomes data on those health visits, and then do PDSA and practice improvement and evaluation during that time to try to adjust clinic processes to make them easier to do and make them more routine as challenges come up, as they inevitably will when you ever try to implement something new. And then the final goal is to report out on that implementation and evaluation. FMEC it has an annual meeting every year where things like this are done all the time. There's opportunities for residents actually to report out in posters or oral sessions. There's opportunities to do plenary sessions, et cetera. But we would ask then that you look at a primary care presentation, hopefully at FMEC or at direct primary care or other integrative or other primary care group. It can be done, at STFM or wherever you would like to do those types of approaches. So that's the primary goals and objectives of the Learning Collaborative as we move forward. Again, I'm going to pause there briefly, see if there's any questions about that. I'm going to go into a little bit more detail on these items, but that's the overall plan for those who join the collaborative.
Just a quick question, Wayne. So I'm assuming there's support along the way when you're talking about implementation and collecting data?
Yeah, absolutely. And in fact, I'll go into that right now to show you the support that's there. Absolutely. We actually have quite a bit of support. This is the faculty that have all agreed to be part of the support system in those areas. I'll be available and helping oversee this. Connie Earle, who's out in Sonoma County and really an expert in integrative health and FQHCs, will be available for that, and she actually helps practices now implement. Andrea Gordon from Tufts University, who is really an expert in implementing integrative and non-pharmacological approaches in chronic pain and opioid use, and she's just completed with her team and with Alan Shaughnessy, who's on the far right there, a CME certificate, 4-session certificate course on how to do this, which will be available to everyone free to be able to do that. Elena, who is actually on the call right now Andrea's at Tufts, and Elena is at Albany Family Medicine, and has been teaching some of these tools now for a year or so. And Alan Shaughnessy, who is an expert in practice improvement, quality improvement, measurement, PDS cycles, et cetera, to help with the evaluation. And I'll stop right there, ask Elena, would you like to say anything as sort of our faculty representative here on this call.
Thank you. Yeah, it's exciting. I think you know, we've worked with Andrea and Wayne, and I'm excited to work with Connie and Alan. Bringing folks with different experiences, I think, will be really helpful to implement across the country. And in my experience, you know, folks at first are a little bit hesitant to start trying something new. And then I'd hear residents saying, well, why don't you try the Hope Note? Maybe that'll help you with this particular patient. So I think it's an exciting time, and I'm excited to be part of it.
Yeah. And we're hoping that also some of the clinics that have been doing this will join the collaborative. Jamaica's already online. Thank you very much. And also there's a network of Join that have been doing it for a while. So there'll be some folks that can be there to actually say, hey, this is what we found works, this didn't work, that's how you adjusted it, et cetera. All right, so am I still okay? Can you still hear me?
I can hear you.
Okay, great, thank you. So the resources, and I'll go into more detail a bit now on some of the other resources besides the faculty. FMEC is bringing a number of resources to the table, including the network, the infrastructure, the opportunity to present, the portal, the data component, Larry and Denise's support in these areas. The Samueli Foundation has developed a number of support approaches for doing this. And our goal is to make those available to you and then help you organize the ones you already have, because you know, you all have things you're doing in this area already, to make it to tap into your local resources. We'll show you some things that that have been found to be often universally helpful, simple things that allow to smooth line the process, and I'll show you a list of some of those in just a minute. Those will all be made available over the 9 months. And then our goal is to help you build your own resource set there based on what you have there to help make the implementation customized to your own area. The general approach that we're looking for all of the programs to do is really set up a process that allows the integrative health processes and resources to be more easily done within routine office visits. So it's something that, you know, theoretically any of your providers could easily learn and begin to do. When I do workshops on this area, I ask the providers to say, all right, start this on Monday. Give out a preparation packet and information, do an integrative health visit, which we sometimes call a HOPE visit, and then provide some of these services in those areas. And we'll be going through this general process on how this is done in those areas. There are a number of other support resources available, and here is a list of some of those, not all of them. I won't go through this list, but these are all will be made available, including onboarding for this collaborative, but also onboarding patients, how to provide an overview to providers and patients. There's a video series on this that shows cases, examples to how to do that. It can be viewed offline. A set of metrics and support and metric collection as you put your evaluation together. There is a coding and payment guide, so you can know how to capture some of this workload in your standard CPT codes if that's what you use. Examples of how this has been put into electronic health records, a variety of patient tools in 3 languages so far. The HOPE visit itself, as well as a solutions guide and a series of videos that derive from a workshop that Andrea, Elena, and I have developed and taught several times. Continued support with the faculty, the monthly learning sessions, data collection, and then a number of sort of follow-up tactics and resources that we will insert during the year so that you can get introduced to things that you either already have and want to enhance or would like to begin to put in. So team care topics, group visits, chronic pain, as I mentioned already from the Tufts group, practice evaluation improvement from Alan, health coaching instruction. A lot of this will be available so that you and your staff can tap into this offline. So you can go and listen to the lectures, do the CME components, et cetera, offline, so that when we have our monthly meetings, we can really spend it talking about the development of the plans, the challenges, the solving of those solutions, et cetera, and learn from the communities. Health coaching skills of some type are often felt to be useful, and we'll talk a little bit about how those get adapted to this kind of routine practice in those areas. So that's an example. There's some other tools that are available, but this is the things that will be made available for that. Here is the timeline. This is a learning collaborative. It is bounded and time limited. We're hoping that we want to keep it within a contained area where you can start it, develop the plan, execute it, and then evaluate the plan. There'll be smaller PDSA cycles within that, but the general outline is over a period of about 3 months. We're introducing the topics, discussing them, letting you learn about the tools, et cetera. And during that time, you can build your care teams and develop the plan for actually executing the visits within your clinic and set up the evaluation components. Then the middle phase is about 5 to 6 months. 5 months listed here. That's when you're actually beginning to implement this in the cohort that you decide to do it in, and gather the data, evaluate that, and then we'll also introduce special topics during that time, depending upon what the group wants and is interested in these areas. The last 3 months are really wrap up, evaluation, analyzing the information, and then creating drafts of your reports, practicing that type of thing. So you'll have the ability to then take this to either FMAC or another primary care presentation. Hopefully, if you all have residents in your access to residents, this can be one of their projects, scholarly projects in that area, and they can participate in that. So that's the general timeline execution. So let me stop there and ask if there's any questions on the general structure, layout, and some of the resources that are available.
General question, Wayne, this is Amin Dhaliwal again. Any idea on the number of hours per week, for example, that are needed to get through each phase? I'm assuming the interim planning is probably the highest amount of time requirement, and then phase 3 probably.
No, that's exactly right. And it's the time outside of clinical delivery that also has to be taken in order to do that. The execution part, it's actually in clinical delivery, and a lot of that can be captured as part of routine care. And then, of course, the evaluation component to put in that the planning and the scholarly component. You are way ahead of me, Aman. I'll show you what we estimate is the amount of time and who should probably be involved to really make this successful. And we're looking at, for you to try to do a little bit of pre-planning and identify who would lead that ahead of time before you join. So, but you're absolutely right in those areas. So here's what those who join, we're asking to commit to. Number one, there is an application. It's pretty simple. And it asks, do you want to participate in this? And if so, who would be the faculty lead? If you have residents, do you have 1 or 2 or more residents that want to participate in it? Are there some behavioral health people that could assist? Because a lot of this involves behavioral health of some type, and some administrative support in those areas. Applications are available from Denise, who's on the line here. If you just email her, she can send that to you. We're also going to ask, what kind of complementary and integrative services do you already have available? What kind of social components do you already have available in these areas? Just to get a biopsy of sort of where the clinics are when we start, so that we can customize it to that. We then are asking you to commit. There's no cost to actually join the collaborative in terms of paying anybody outside of your clinic, but we're asking that you at least have 1 or 2 faculty leads or staff lead, 2 or 3 residents if you can, if you have residents, or other clinic providers that would want to be part of this, and some behavioral staff, as I said, available, and some administrative. We're estimating about 10%, especially for faculty and residents. The coordinator and the health coaching ought to be things that could be provided in the care delivery, but we're asking about 10%. But as you've pointed out, Ahmed, that's probably front-loaded largely, and then in the evaluation component in those areas. It may vary depending upon, how far in you want to get on this, okay? If you want to really get 4 or 5 practitioners going and have them up and running in several clinics and that type of thing, then certainly can do more. But we think this is sort of the minimum time to really make it worthwhile to your practice to actually have it done in those areas. Over that 5 months, it's reasonable, I think, for most practices to do about 50 patients per provider of these visits. And again, if you can do more than that, that's great. But it's fairly easy to put into the workload about 50 patients during that period of time, and then to capture that information. So during that early time, also would ask everyone to develop a plan for both implementing it. In other words, picking a populate kind of evaluation that you want to implement in this. And I'll show you some examples of recommended evaluation. Okay, can you still hear me?
Yes.
Okay, great. You just get a signal that my internet is unstable. And then to evaluate and collect the data, and then report back at the monthly meetings. We ask everybody to commit to the monthly meetings. These we'll block out 2 hours, but we'll plan about an hour and a half every month. We've selected some times for that right now, but that'll be adjusted after people join to make it convenient for everybody. We'll ask people to offline look at any kind of lecture material and CME kind of things to get familiar with the tools, so that these meetings are really spent interacting. The faculty and staff will be assigned to clinics, and so they will be available in between these monthly meetings to assist in any kind of troubleshooting or access to materials or discussion of evaluation plans during that time. And so during the monthly meetings will be a time really for the clinics to begin to share with each other. Depending upon the number, we'll break them out and have people then talk about what's going on, ask for other solutions that people have come by, during that time, and generally exchange information about how things are going during that time. And again, the faculty will be available in between that, to touch base, every couple of weeks or earlier if necessary, as things get set up. Here's the data collection. The evaluation plan really needs to be customized to what your clinic needs. So for example, if you decide you've got a chronic pain, an opioid use clinic or a chronic pain clinic, as mine does, then that might be the cohort you would look at. And then we'll probably have Andrea or somebody who's expert in that area be assigned to your clinic to do that, and then you would want to collect data on the impact of that in your chronic pain clinic. If some have wanted to do diabetic clinics or others more general clinics. The only thing we're asking you to do that would allow us to compare this across all clinics is to use some wellness assessment tools. Because the goal of integrative health is to improve health and well-being in a generic way for anybody, regardless of their diagnosis. And so here's some of the tools that will be available to do that. One's called the Personal Health Inventory. This is a tool that really starts the conversation with patients. It's filled out by the patient, and it gives a snapshot of where they are in their health. It has embedded in it something called Healthy Days, which is a CDC validated tool in the bottom for measuring just general health. We're asking people to engage and then just do an actual hope note, and there's a structure for that and how to do that. We'll be just counting up those and how they do that. We're also asking people to try to get all of the people that have an integrative health visit to also fill out the Promise 10 questionnaire. This is an NIH validated 10-question PRO, patient-reported tool that captures mental health, physical health, pain, fatigue, and overall general health. And this allows for not only comparison within the network, but also to standard population data that's available from the NIH in these areas. So this is what we'll be asking everybody to do. We'll have assistance in helping putting that together. We realize that probably every clinic will have other things that they want to collect in this. As I mentioned, depending how they're going to want to do that. Some may want to look at resource utilization like ED visits and hospitalizations. Some may want to look at cost issues and reimbursement capture and this type of thing. And that's all fine. You can implement those in during the planning phase. We'll assist you if needed, to get those into your evaluation component in those areas. The more diverse the evaluation, the more you can learn from. But these are the core components we'll ask everybody to at least capture so that we can begin to share in those areas. And then finally, we'll ask you to attend all the monthly meetings. Again, we picked a time right now, but that can be adjusted. And to put together a wrap-up to present at some primary care meeting at some point. And there'll be an opportunity to practice it among the group, towards the end of the meeting. So that is pretty much it right there. That's the goal. I hope we've provided information to talk about how we've organized this and just open to any other kinds of discussion or questions, comments from the group.
I had 2 quick questions. So did you say 50 visits per month per provider or 50 visits total for them?
Yeah, so we recommend, thank you for that question. That's great. We recommend for a provider that starts in this, I'm going to actually stop sharing here so people don't have that in front of them. We recommend 50 for providers. So if you have 1 or 2 faculty that say, yeah, I'd like to be part of this, I want to try this out, a couple residents, then we recommend within that 5-month period, they should be able to do at least 50 integrative health visits. Because remember, we're trying to implement this in sort of their standard care and try it out. And that seems to be a very reasonable number. It's very easy to do. It's not too much. So that's what we're going to recommend. I mean, we're not going to kick you out or anything if you can't do that. But, I know up there, Jamaica, you were all ready to start launching all this. And then we had you all had a little diversion, didn't you?
Just a little bit.
Called hitting by the bomb of COVID. You guys were in the center of the storm there. So, it wouldn't have required that. But, that's something I think under normal circumstances. It's interesting. I'm doing a lot of these now, and I'm doing the vast majority of them virtually. And so we're going to be building and have started to build online tools to be able to do this virtually. It works very well for some patients. Other patients, need other help. If you already have the diagnosis, you've done your SOAP notes, you know these patients, et cetera, then doing it virtually is actually pretty easy to do. They like that. We've done also virtual group visits, which has actually worked quite well. And during this session, we may bring in somebody who does group visits that many of you know, Jeff Geller, who's doing that to introduce group visits and that type of thing. So, so I think in the peri-COVID world, when more and more is getting virtual, I think this lends itself fairly easy to that delivery approach.
Thank you. And my other question was just, what are kind of the outcomes we're looking for? So I totally get the metrics part about how many quote notes, how many promise tents. How do you measure the outcomes in the 5 months? I'm just trying to see what my goal is before I start to kind of understand the,
No, that's a great question. I mean, the outcomes overall, other than the ones that I showed you, or the required metrics, are really based on what you feel like is going to serve your practice and clinic most usefully in the population that you're going to be looking at. So, so during the planning phase, that's part of what you'll be putting in and deciding on which outcomes you want. In general, for this fairly short period of time for chronic illnesses, engagement is a very important thing. How many patients have you seen? How many actually have engaged? And you can measure some of that by the number of people that come back, the number of touches, the number of integrative encounters that occur, and we can actually show you that. We have a whole data list that will provide you, that show you different metrics organized by quadruple aim, okay? Cost, clinical outcomes, satisfaction, and burnout issues in those areas. And so we'll make those available. You can, pick from those if you'd like, but you can, customize whatever you have that are part of your standard data collection processes in your clinic.
Thank you.
Other comments, questions?
One quick question. In the absence of an integrated behavioralist in your own clinic, would this still function, or is that just going to be too much of a gap to make up? I could see some nodding heads are familiar with it.
Yeah, great question. So I do this in 2 clinics. One has 2 health coaches readily available, okay? And we plug them right in. They, know what to do, et cetera, et cetera. Another clinic that has none, okay? They have administrative assistant, does a little bit of health coordination, et cetera, and that's it they have. And they do have a behaviorist available for the entire practice, which is a huge practice, but they are so busy just doing mental health and other consults that they can't participate in this. And so what we've done is that we've trained the health assistants who have not, some of which do not have huge medical training, but they can do this to act as facilitators for patients and also health coaching. So they don't necessarily have to do the full-blown certification in health coaching, but we have tools with video examples and and resources that they can readily use and tap in. So in the clinic where there's no health coaching, they have been they've been able to adopt these kinds of tools pretty quickly, and the patients then get in touch with them. They're part of the team, and they facilitate the integrative health touches. Some of it's navigation, and some of it's health coaching components. With your health assistants or your health navigators.
And you may be just some, we don't have, we have one licensed mental health clinician in the practice, but we also have community health workers in the community. And I think there's potential for working with community health workers and the community health coaches in the community and having them, integrating them into these workflows. So even if you don't hire them and you don't pay for them specifically, there may be ways that you can work with orgs that have them.
Yeah, no, that's absolutely right. Community health workers pick up on this immediately. They're doing a lot of this actually in many ways. And so it's a matter of creating the sort of the coordinated handoff and interaction with them to make it happen. We have also, just for those of you that may not have availability of some of these so-called CAM or complementary medicine providers available, that's something we don't have in many of our clinics. For example, an expert in chronic pain for yoga provider. Yoga, very effective non-drug modality, acupuncture, very effective non-modality. Part of the setup, if you have them available in your community and you can tap in and make available to them, we have guides for how to do that. And then, you can customize based on what your resources there as to what's available. The primary tools we try to make available are ones that don't require a lot of that, because we realize many practices don't have that. Many of them are stress management, mind-body approaches, educational components, health coaching aspects. There's a number of free tools for imagery, for example, mind-body practices, nutritional education, et cetera, that are available. And we try to make those available so that any provider can say, here's the tools, let's try this out. What is meaningful and doable for you? Let's get that into your plan, okay? And at the end of the Hope Note week, there's a form you'll see, and a format to help put it into what's called a personal health plan. And it lays out, what you do now, how you follow up with them in 2 weeks to create SMART goals and move that plan along, and then how you follow them up with in 2 or 3 months to check on those components. So those are, and many of those things have support tools that you can readily just download and adopt and begin to implement, and then fill that out more fully with the resources that you have available in those areas with things like that Elena has mentioned, for example. Any other comments or questions? Larry, did you have anything else you wanted to add, or?
So one of the things that we will be doing as applications come in and applications are accepted is we will be preparing people to use the FMEC website. We have some tools that will allow this group to communicate. And there's a listserv function in there, so you're able to communicate with the members of the group. There's a place for storing documents. And we will provide everybody with a free FMEC membership, which is only $50 a month, but it allows you to join through the website. So that will be offered as programs or individuals are accepted into the learning community. So
actually, sorry, that actually brought up an interesting question. I had this earlier. Thanks for bringing it up, Larry, because it kind of refreshed my memory. Is there any kind of IRB process required? Because it seems like we're storing or looking at some kind of data. And then you mentioned that there's a site for some kind of data repository on the FMEC website. How does that work?
Yeah.
Wayne, you want to talk about?
Yeah, so the data components that I showed you previously, we're asking should be basically practice numbers. And so we're not looking for any kind of individualized data. We're looking for practices to summarize, number of visits they've had, aggregate scores, et cetera, and then to load those in as they're collected every month from the practice and any kind of practice improvement issues that come along. So this is fundamentally a practice improvement process that we're using. Now, so the collaborative as a whole, we do not believe will need and shouldn't need an IRB component, because it's just practice improvement and facilitating that area. We will check with Alan and others as we sort of get into it in more details to make sure there doesn't need to be some general IRB assessment. Now, if you're going to be wanting to look at in your own practice, sort of individual data that then links up to electronic medical record and begins to get more refined detail with patient identifiers within your own practice, then you'll probably have to go through and get approval from your IRB to do that in your own practice. But that's not the data we're asking for in those areas. So
published, ultimately, then it would need IRB approval, even though it would be exempt. So if you're ever thinking you're going to publish this data as a whole, then you need to do IRB before you start.
right. And is that, Mary Jo, is that true for the overall learning collaborative also?
Yes, if you're ever going to publish it as the IRB chair currently.
Even if it's considered practice improvement data? Because people do practice improvement all the time and then present on their practice improvement. And I guess
again, it'll be exempt, but you have to have that exempt status before you start.
Yeah. Yeah, so I think that's wise. That allows you more flexibility in the data that you're collecting, and so if you can get exempt status, this should provide exempt. I would hope it would easily provide exempt data status. You're not, it's not a randomized controlled trial of an experimental therapy here. These are all evidence-based components that are being done as part of behavior and lifestyle and that type of thing readily. But it should be run by. Whether we need an overall IRB component, it's a good question. I've heard both people recommending it, and Mary Jo, sounds like you are recommending it, but I've heard other people saying that it's not necessary for a learning collaborative here. If it is necessary, then we will, seek out one of those, Western IRB or one of the other mainstream groups to do that.
Most legitimate journals will require you to show an IRB even for something like this. And I'm seeing Elena nodding her head as well.
Yeah. Okay. Well, we have available some overall arching IRBs if the collaborative as a whole needs to do that. So, all right. Okay. Any other questions?
So if anyone has questions following the meeting, contact me directly or contact Denise Steele and she'll alert me. But whatever questions or issues come up, we're here to help.
Yeah.
Okay, thank you.
I think then, and the next step would be then to submit an application to Denise, and she can send you the forms for that.
All right, thank you.
All right.
Great. I think we're done.
Thank you all very much.
Thank you,
very much.
everybody.
Bye-bye.
Bye-bye. Take care.